Today we will be discussing the lower limb bones. Already we are teaching you. Now this is the hip bone, this is the femur, and femur articulates with the tibia, and this is the fibula. Now this is the patella. Now your side determination. Now every bone, long bone, it's a long bone. It has an upper end, lower end. This middle portion is the shaft. Now the upper end articulates with the lower end of femur. The upper end articulates with the lower end of femur. You see the lower end of the femur, and it forms the knee joint. It forms the knee joint. Now you have, now I am holding two tibias. One, this is the right side, this is left side. Now the right side, the side determination. Why I am saying right? If I hold it, now the portion, this is the medial malleolus, medial malleolus. You see your own anyway, you see your own, this is the medial malleolus. Now, this is the medial malleolus. See, this is the tongue-like, tongue-shaped. It will be on the medial side. Medial side. It is also known as the shin bone, the sharp anterior border. Okay. And the upper, the condyles, the upper end. So don't hold it like this. Don't hold it like this, because this is the sharp shin. This is known also shin bone. This is a tubercle there, this in front anteriorly, shin anteriorly, and the upper, the globular part, the upper end, and your medial malleolus, this is the medial malleolus, is on the medial side, medial side. So you don't do this, don't do this, don't do this, don't do this. No Bhelki, no magic. Gilli, 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 go. PC Sarkar. Okay. Now, what I want to say is that you just see, no. I'm saying the practical part, your 3 batches. But আমি যেটা বলি, আমি যদি থাকি আর কি, what I would like, in your just assessment examination, I'll ask you what you read the best in last morning revision. Which you read? You say for femur, or you say tibia, or you say your hip bone, or sacrum, whatever is your choice. I give a choice. Leave aside a choice. If the examiner says, pick up this. You just don't do this, don't do this, don't do this. You just pick it up. Just one common description there is the long bone has an upper end or lower end, and it has a shaft. Middle portion is known as the shaft. The upper end you now describe. Now between the femur, this is also a long bone. Now femur has a where it articulates, and the femoral condyles, the lower end of the femur, articulates with the upper end of tibia to form the knee joint. Similarly, the upper end of the head of the femur articulates in the acetibular cavity, the socket, acetibular cavity, to form the hip joint. Am I clear? Now, side determination, you see the medial malleolus. This is the medial malleolus. it is having an anterior border. You hold it, now you hold it, you start saying that this is the tibia of the right side because it is having the medial malleolus in the medial side and the tubercle in front, the upper end upwards, and the shin part is anteriorly. Now the difference is that you see this is the shin, this is the tubercle, this is the upper end. Now you can hold it like this also, but you see the medial malleolus is gone laterally. Rocky, at a fibula near, at a fibula. Oh, it's here. Now see the fibula is here. There is a small part on the lateral side. Okay? It's in the lateral side. Now what I want to say is that you see the দেখো তোমরা দেখবে আর আমি আমার কাছে আগে শুনে নাও দেখে নাও তারপরে তোমরা নিজেরা ইয়ে করবে there is an articular facet here. For the upper end of the fibula, it articulates. The lower end goes in the fibular lateral malleolus. You get it? Tubercle front. The anterior border, sharp anterior border, shin, it is anteriorly. Upper end, now upper end articulates with the lower end of the femur, the two condyles, to form the knee joint. That gives you 10 marks. আছে আমি তিনটে বোন ধরবো তিনটে 3. Now 3 bones, one might be from the head and neck. Don't panic. Temporal, sphenoid. Don't. If you are the day you are giving your exam, you are the boss, and we might have forgotten anatomy. And taking kaju, green tea, and talking, but my ears is sharp. If you say something wrong, he'll take catch. So if the examiners are talking, don't bother. You go on saying. And see, now this is the upper end of the tibia. The femur, the body weight, and see the hip joint, knee joint, they are very stable joints. Because you see football, Ronaldo giving 100 goals or 1000 goals in penalty box. Who plays football here? You? हाथ तोलो भाई इतना शर्मिंदा नहीं है अरे भाई okay. You always actually football is a game. I think every boy has to be, when they are bringing up, to take football, because football has a different your coordination. Now this hip bone, I think previous day I showed you the evolution of erect posture, the Valentine Day skeleton dancing, Shalsa. So you can see the total movement, the range of movement. Now also the stability. फट করে দেখো খুলে গেল, but হাত খুলে যেতে পারে. The shoulder joint is unstable. It might get a dislocation, but a hip joint or knee joint dislocation, you have to get a thrust, a massive force to this thing, there might be a dislocation. Now the upper end, now it articulates with the lower end of the tibia. Now it's a synovial joint and it is surrounded by cartilage, synovial fluid. And see one thing, Now actually the upper end, you see the irregular. It's like a plateau. It's like a plateau. Which country is a plateau? Which country? Many places are there. Even in India we have plateau. But I'm telling you, a troubled state and a Buddhist state taken over by China, Tibet. So it's like this. So the Tibet is a plateau. Similarly, this is a plateau. Now, you see your upper end. Please see, please view. Usko dekho. Now, it has to be, I told you this joint. Now, like this. Now, these movements are actually, it has to glide, it has to move, it has to, you will see some people are doing like this, some kicking, dancing, salsa. I actually, in our school, we used to have socials, Side, your Loreto Convent School was there, girls. So we used to have sessions, dancing session for Mother Teresa's charity. So, we had our days in those days, and I love dancing actually. Two things I cannot do is driving and riding a motorbike. So people question me, I tell them that, have you seen Jati Basu or Pranab Mukherjee or Manmohan Singh driving a car? So I don't drive. Okay. Now that's a joke. Now you see the semilunar cartilage, it is wedge shaped. When you see in the dissection, you will see it's a wedge shaped semilunar cartilage. This is the lateral meniscus. This is the your medial meniscus. You see this arrow, anterior, medial, lateral, posterior. Over here is the tubercle. The tubercle. Now it is the knee joint is very, it doesn't move like this. There can be a meniscal injury, especially in footballers or anyone with a wrong foot and it gets twists, then there is a meniscus injury because the tendon of popliteus comes, and that is when you read the locking and unlocking, then you will they will teach you that how is it is affected. Now the side is the coronary ligaments forming the knee joint, the intertubercular sulcus, and from these are the anterior horns of the menisci. This is the posterior horn, anterior horn, and posterior horn. Now the posterior aspect you see, and this part is the anterior tubercle, that is the ligamentum patella, and also the bursa is there in front, and posteriorly the ligamentum patella. And in some people or a woman, they come with a complaint that the swelling, tumor. No, you have to assure that it is not a tumor. Sometimes professionally when they sweep or they are sitting down or something like that, postural, something's postural, then there is a bursitis. But you have to manage how you have to, that's a clinical part. Another thing is that the upper end is a must questions. Short note, describe the upper end of the tibia and its attachments and all this. Even in Viva they ask you anterior cruciate, from anterior to posterior. You have to say from what the meniscus, the collateral ligament, everything. And then they might ask you the posterior aspect. Now the posterior aspect is a transverse ridge, the soleal line. This is the soleal line. Now the muscles are attached accordingly. The soleus muscle is here, and there are your, when you read the hip joint, then now there are some muscles that is attached from this place to the your tibia, like sartorius, gracilis, semimembranous, semitendinous. Now semimembranous, semitendinous come from your ischial tuberosity of the hip bone. And now this is one part. Another thing is that your fibula. Now see, please এখানে বসে থাকো, পৌনে দুটোর সময় বেরোবে। যখন তোমার কোনো ইচ্ছে নেই, বসো, ভিডিও দেখো। এটা কেউ কিন্তু তোমাদের দাদারাও করেনি, কিছু করেনি, তোমরা করে দেখো। এই পিরিয়ডটা তুমি যেতে আসতে গল্প করতে করতে চলে যাচ্ছে, 45 মিনিট চলে গেল। But if you see 45 minutes video in your demonstration class, even the teacher, whoever is taking the class, he teaches you and goes and again comes back. So you all, any time when you are in dissection hall, there is a crowd in the demo. When the teacher is teaching, you are sitting here. এদেরকে বলবে চালিয়ে দেবে, এদেরকে বলবে চালিয়ে দেবে, তাহলে কি হবে? চলো, লাইনে সোলিয়াস মাসল এভরিথিং, এই লিগামেন্ট, কিন্তু দিস ইজ আ প্লাস্টিসাইজড বডি. Plasticized body, you will see the muscles, how it is being in action. Real imagery টা পাবে. Dissected part, it is formalin. But you have to see, identify muscles.
The patella, which is here, is encoded within the tendon. Upon the tendon below the patella is known as the patellar ligament.
It's a patellar ligament. It is not plastic, it's a human body plasticized. See, quadriceps bursa.
This lubricated pocket enables the quadriceps to slide easily on the femur. Now we will complete our picture of the joint by adding the fibrous capsule to enclose. Here's the knee joint with the joint capsule intact. On the medial side, the thin capsule is continuous with the tibial-collateral ligament. But on the lateral side, the capsule is separated from the tibial-collateral ligament. On the back of the joint, the capsule is thick and strong.
See the whole capsule, but even in the, when you dissect out, you will see the capsule. But this is, see, I am moving. Similarly, they are showing you like this.
On the inside, with synovial membrane all the way around the joint, except for that.
The condyles of the.
As we'll see if we remove the capsule, the thin synovial membrane area passes forward around the cruciate ligaments, covering them on the front. Besides being the largest joint, the knee joint is also massively complicated. Before we move on to the muscle distribution, let's review what we see at the bone and the knee joint. On the femur is the lateral condyle and epicondyle, medial condyle and epicondyle, the adductor tubercle, and
This is the lower end of the femur.
on the tibia is the lateral condyle, the medial condyle, the tibial tubercle, and the facet for the fibula. Here's the head of the fibula, the neck of the fibula, the proximal tibial fibula, and the patella. Here's rotates the medial
See,
meniscus,
the cartilage which I drew,
the
now you
lateral
see it in
meniscus,
reality.
the anterior cruciate and posterior cruciate ligaments, the fibula ligament, the tibial ligament, the quadriceps tendon, the patellar ligament, and the joint capsule. Now we'll move on to look at the muscles which produce movement at the knee joint. We've met most of them already. The one muscle that extends the knee is the massive quadriceps. We saw it briefly in the last section. We'll take a better look at it now. The main flexors of the knee are the so-called hamstring muscles, semimembranosus, semitendinosus, and biceps femoris. Besides flexing the knee, the hamstring muscles also extend the hip. We took a good look at them in the last section. Here, we'll just revisit their insertions. In addition, we'll look at three muscles at the back of the knee that we haven't yet seen: popliteus, gastrocnemius, and plantaris. We'll start with quadriceps. Its name comes from the fact that it has four heads. Oddly, these are named as though they were separate muscles. Three of the heads arise from the femur. They're called vastus intermedius, vastus medialis, and vastus lateralis. The fourth head, rectus femoris, arises from the hip bone. All four heads converge on the quadriceps tendon, which we've seen. We'll start with the deepest of the heads, vastus intermedius. Here it is. It forms a bulge on the front of the femur. Vastus intermedius arises from this broad area around the lateral aspect and front of the femur. Wrapped around the outside of vastus intermedius are vastus medialis and vastus lateralis. These two cover vastus intermedius almost completely. Their fibers run looping all the way around to the back. Here's lateralis, here's medialis, almost meeting it. Vastus lateralis arises from the lateral edge of the linea aspera and from the side and front of the greater tendon. Vastus medialis arises from the medial ridge of the linea aspera and from just below the lesser tendon. The thin strip of bone between these two lines of origin provides the insertion of all the adductor muscles and also the origin of the short-haired biceps. Now let's add rectus femoris to the picture. Here it is. Rectus femoris arises from the ilium just above the hip joint. Its tendon of origin has two parts, a posterior or reflected part and an anterior or straight part. The anterior part arises from this prominence, the anterior inferior iliac spine. The posterior part arises from just above the acetabular. All four heads of quadriceps converge on the quadriceps tendon. The lowest fibers of vastus lateralis and medialis insert onto the sides of the patella. The principal action of the quadriceps muscle is to extend the knee. When the foot is off the ground, that action simply straightens the leg and holds it straight. When the foot is on the ground, the action of the quadriceps has several important effects. In normal walking, quadriceps straightens the leg as the foot reaches the ground, then keeps the leg straight while the hamstring muscles extend the hip. Quadriceps is also one of the two big anti-gravity muscles of the lower extremity. Its partner, which we've seen already, is the gluteus maximus. Acting together, quadriceps of the knee and gluteus maximus of the hip lift the body upward when we climb uphill, when we rise from the sitting position, and when we jump. The same muscle actions propel us forward when we're pushing a heavy load. In addition to these actions, when quadriceps and its partner, gluteus maximus, act in balance with the force of gravity, they control control our rate of descent as we sit down. And also when we walk down a hill. We need to digress for a moment to look at a structure called the adductor canal, which lies between vastus medialis and the adjoining adductor longus muscle. The adductor canal is important because the femoral vessels run through it in their course from the front of the thigh to the back. Here's vastus medialis. Here are the adductor muscles, magnus behind, longus in front, and brevis up here. The adductor canal is formed by the groove between adductor longus and vastus medialis, and by a disjunctive fashion called the root of the adductor canal, which bridges over between the muscles.
টিবিয়াটা দেখা
The adductor canal is covered over by the sartorium. They both form the Fibula. All the muscles of the lats and the teres are known as the relevance. Here it is, the biceps femoris. Breathe. Having put into are called dorsiflexion. The proximal and distal tibio-fibular joints. It's the medial supracondylar line. The sharp corner on the medial epicondyle is the adductor tubercle. This prominent ridge is the medial supracondylar line. This one is the lateral supracondylar. This is the medial condyle. This is the lateral condyle. On top of the two condyles are two quite separate articular surfaces. They're much flatter than those on the femur. The rugged expanse between the articular surfaces is the interarticular area. This prominent lump on the front, the tibial tubercle, is the final insertion of the quadriceps tendon. The small passage under here is for the fibula, which we'll add. This is the head of the fibula. This is the neck. The head of the fibula is the point of attachment of a major ligament of the knee joint, as we'll see. The space on each side of the knee between the femoral condyle and the tibial condyle is occupied by a crescent-shaped piece of cartilage, a meniscus, which we'll see shortly. The space in the middle, the intercondylar notch, is occupied by the two cruciate ligaments. The intercondylar notch and its contents divide the knee joint into two almost separate parts. There's one more bone to add to the picture, the patella, or kneecap. The patella, as we'll see, is embedded within the quadriceps tendon, which comes from here, and it sits on the tibia down here on the tibial tubercle. On the back of the patella, the articular surface is divided into facets. These articulate either with the femoral condyles when the knee is placed, or with this central articular area when it's extended. Now that we've seen the bones of the knee joint, let's see how the joint looks in the living body. In building up our picture of this quite complicated joint, there are several structures that we need to understand. First, the two joint cartilages on the menisci. Then the ligaments, the two cruciate ligaments and the two collateral ligaments. Then the patella and the quadriceps tendon on the front. And lastly, the capsule, which encloses the joint. Here are the two articular surfaces of the tibia. The two menisci sit on top of them. Here are the menisci. They're made of flexible fiber cartilage. They're shaped a little differently. The lateral one is almost a circle. The medial one is more C-shaped. In cross-section, each meniscus is thick at the outer edge and thin at the inner edge. The two ends of each meniscus are attached to the interarticular area of the tibia. The medial ones are apart. The lateral ones close together. In addition, each meniscus is attached all the way around its edge, but above and below, to the joint capsule. Here's part of the joint capsule, We'll see more of it later. The lateral meniscus is much more mobile than the medial one, partly because its two ends are attached close together, partly because of the big difference in the mobility of the joint capsule around the edge. By filling in the spaces between the femoral and tibial compounds, the menisci produce an even distribution of synovial fluid to nourish and lubricate the articular cartilage of the femur and tibia. Now let's look at the two sets of ligaments which hold the bones together at the knee joint. The two cruciate ligaments on the inside and the two collateral ligaments on the outside. We'll look at the cruciate ligaments first. They're the important structures which prevent forward and backward movement of the femur on the tibia. Their name comes from the fact that they form a cross, like this. Here's the anterior cruciate ligament, seen from in front. Here's the posterior cruciate ligament, seen from behind. To get a better look at them, we'll remove the lateral condyle of the femur. Now we can see the whole of the anterior cruciate ligament. The anterior cruciate ligament goes from here on the tibia to here on the femur, on the inner aspect of the lateral condyle. The anterior cruciate ligament prevents the femur from moving backward in relation to the tibia. Now we look at the posterior cruciate ligament. We'll remove the anterior cruciate ligament to see it better. The posterior cruciate ligament goes from here on the femur to here on the back of the tibia. The posterior cruciate ligament stops the femur from moving forward on the tibia. By preventing backward and forward movement, the cruciate ligaments ensure that the condyles of the femur stay in one place as they roll on the condyles of the tibia. Without them, the femur would roll off the back of the tibia in flexion and would roll off the front of it in extension. Now let's look at the two collateral ligaments. The fibular collateral ligament on the lateral side and the tibial collateral ligament on the medial side. The tibial collateral ligament goes from the medial epicondyle of the femur to the anteromedial aspect of the proximal tibia. The tibial collateral ligament blends with the capsule of the knee joint behind and also in front. On its inner aspect, it's firmly attached to the edge of the medial meniscus, which is here. Now let's look at the rather different fibular collateral ligament. It goes from the lateral epicondyle of the tibia to the head of the fibula. The fibular collateral ligament stands out from the side of the knee joint. Unlike its tibial counterpart, it doesn't bend with the joint capsule. It's not attached to the meniscus. When the knee joint is extended, both the collateral ligaments are tight. In its place, they become less tight. The function of the collateral ligaments is to keep the femoral and tibial condyles together, and thus to prevent the knee joint from bending from side to side, like this, or like this. In addition to the obvious knee movements, flexion and extension, it's also possible for the tibia to rotate a little on the femur, like this. This rotation can happen only when the knee is flexed. When it's extended, the tightness of the collateral ligaments makes rotation impossible. The next structure we need to add in building up our picture of the knee joint is the quadriceps tendon, and along with it, the patella. Here's the distal end of the quadriceps muscle, which we'll see in more detail later in this section. Here's the quadriceps tendon. The patella, which is here, is enfolded within the tendon. The part of the tendon below the patella is known as the patellar ligament. On the medial side and on the lateral side, the tendon is continuous with the capsule of the knee joint. Between the quadriceps tendon and the femur is an extension of the knee joint cavity, the quadriceps bursa, It's lined with synovial membrane. This lubricated pocket enables the quadriceps tendon to slide easily on the femur. Now we'll complete our picture of the knee joint by adding the fibrous capsule which encloses it. Here's the knee joint with the joint capsule intact. On the medial side, the thin capsule is continuous with the tibial collateral ligament. But on the lateral side, the capsule is separated from the fibular collateral ligament. On the back of the joint, the capsule is thick and strong. The thickened posterior capsule prevents hyperextension of the knee joint. Here, we've divided the fibrous capsule to see its inner surface. It's lined on the inside with synovial membrane all the way around the joint, except the back. At the back, as we'll see if we remove the capsule, the thin synovial membrane, here it is, passes forward around the cruciate ligaments, covering them on the front. Besides being the largest joint in the body, the knee joint is also much the most complicated. Before we move on to look at the muscles which produce the knee movement, let's review what we've seen at the bone and the knee joint. On the femur is the lateral condyle and epicondyle, medial condyle and epicondyle, the adductor tubercle, and the intercondylar notch. On the tibia is the lateral condyle, the medial condyle, the tibial tubercle, and the passage to the tibia. Here's the head of the fibula, the neck of the fibula, the proximal tibial joint, and the patella. Here's the medial meniscus, the lateral meniscus, the anterior cruciate, and posterior cruciate ligaments, the fibulocollateral ligament, the tibial collateral ligament, the quadriceps tendon, the patella ligament, and the joint capsule. Now we'll move on to look at the muscles which produce movement of the knee joint. We've met most of them already. The one muscle that extends the knee is the massive quadriceps. We saw it briefly in the last section. We'll take a better look at it now. The main flexors of the knee are the so-called hamstring muscles, semimembranosus, semitendinosus, and biceps femoris. Besides flexing the knee, the hamstring muscles also extend the hip. We took a good look at them in the last section. Here, we'll just revisit their insertions. In addition, we'll look at three muscles at the back of the knee that we haven't yet seen: popliteus, gastrocnemius, and plantaris. We'll start with quadriceps. Its name comes from the fact that it has four heads. Oddly, these are named as though they were separate muscles. Three of the heads are running through the femur. They're called vastus intermedius, vastus medialis, and vastus lateralis. The fourth head, rectus femoris, arises from the hip bone. All four heads converge on the quadriceps tendon, which we've seen. We'll start with the deepest of the heads, vastus intermedius. Here it is. It forms a bulge on the front of the femur. Vastus intermedius arises from this broad area around the lateral aspect and front of the femur. Wrapped around the outside of vastus intermedius are vastus medialis and vastus lateralis. These two cover vastus intermedius almost completely. Their fibers run obliquely all the way around to the back. Here's lateralis, here's medialis, almost meeting. Vastus lateralis arises from the lateral edge of the linea aspera and from the side and front of the greater canthus. Vastus medialis arises from the medial edge of the linea aspera and The thin strip of bone between these two lines of origin provides the insertion of all the adductor muscles and also the origin of the short tail of biceps. Now let's add rectus femoris to the picture. Here it is. Rectus femoris arises from the ilium just above the hip joint. Its tendon of origin has two parts, a posterior or reflected part and an anterior or straight part. The anterior part arises from this prominence, the anterior inferior iliac spine. The posterior part arises from just above the acetabular. All four heads of quadriceps converge on the quadriceps tendon. The lowest fibers of vastus lateralis and medialis insert onto the sides of the patella. The principal action of the quadriceps muscle is to extend the knee. When the foot is off the ground, that action simply straightens the leg and holds it straight. When the foot is on the ground, the action of quadriceps has several important effects. In normal walking, quadriceps straightens the leg as the foot reaches the ground, then keeps the leg straight while the hamstring muscles extend the leg. Quadriceps is also one of the two big anti-gravity muscles of the lower extremity. Its partner, which we've seen already, is gluteus maximus. Acting together, quadriceps of the knee and gluteus maximus of the hip lift the body upward when we climb uphill, when we rise from the sitting position, and when we jump. The same muscle actions propel us forward when we're pushing a heavy load. In addition to these actions, when quadriceps and its partner, gluteus maximus, act in balance with the force of gravity, they control our rate of descent as we sit down. And also, when we walk downhill. We need to digress for a moment to look at a structure called the adductor canal, which lies between vastus medialis and the adjoining adductor longus muscle. The adductor canal is important because the femoral vessels run through it in their course from the front of the thigh to the back. Here's vastus medialis. Here are the adductor muscles, magnus behind, longus in front, and brevis up here. The adductor canal is formed by the groove between adductor longus and vastus medialis, and by this sheet of fascia called the roof of the adductor canal, which bridges over between the muscles. The adductor canal is covered over by the sartorius muscle. We'll see the adductor canal again when we look at the blood vessels. Now let's move on and look at the muscles which produce flexion of the knee joint. We'll revisit the main flexors, the three hamstring muscles, and two minor flexors, sartorius and gracilis. Here are the hamstring muscles again. On the medial side, here are semimembranosus and semitendinosus. As we've seen, they both arise from the ischial tuberosity and insert on the medial side of the knee. Semimembranosus here, semitendinosus here. On the lateral side, here's biceps femoris. It arises both from the ischial tuberosity and from the femur. It inserts down here on the head of the tibia. We've already seen that these three muscles, which usually act together, can produce either extension of the hip or flexion of the knee. Whether they do one, the other, or both is determined by what other muscles are acting in opposition.
Muscles are attached. So you can see where it is originating and getting into the tibia.
When extension of the hip is resisted by the hip flexors, the hamstring muscles produce flexion of the knee. In addition, the hamstring muscles, acting separately, produce medial rotation and lateral rotation of the knee joint. As we've seen, these movements can only happen when the knee is flexed. The two semi-muscles produce medial rotation. Biceps femoris produces lateral rotation. The other two minor knee flexors that we've seen already are sartorius and gracilis. Here's sartorius, which arises here. Here's gracilis, arising here.
Originating from the hip bone, and see it's getting attached here. Sartorius and this thing is the upper end of the tibia, on the medial edge.
We've already seen the actions of these two
on the medial side.
At the knee, they help to produce action. Now we'll complete our picture of the muscles around the knee by looking at three muscles at the back that we haven't yet here: popliteus, gastrocnemius, and plantaris. Here's the popliteus muscle. It arises from this area on the back of the tibia and inserts up here on the lateral epicondyle of the femur. The tendon popliteus passes through the capsule of the knee joint to reach its insertion. Popliteus is a minor flexor of the knee.
When the knee joint is this thing, then you're locking, unlocking of the knee joint. The popliteus, you have to describe from origin and where it is getting inserted.
It rises from the lateral epicondyle of the femur. The tiny tendon of plantaris runs down on the back of this big muscle, soleus. You'll see where it ends up in the midsection. Lying on top of the two small muscles that we've just seen is the much larger gastrocnemius muscle. Gastrocnemius arises at two heads from the back of the medial and lateral condyles of the femur. Gastrocnemius runs downward and joins with underlying soleus muscle, which we'll see in the next section, to form the calcaneal tendon, or heel cord. Gastrocnemius has a slight flexing action at the knee, but its main action by far is at the ankle joint. We'll see it again in the next section. Now that we've seen all the muscles that arise or insert in the knee joint, let's see how they all fit together. You can use this overview as a brief review section. Here on the front are quadriceps, sartorius, and gracilis. On the back, here is semitendinosus and semimembranosus. Here's biceps femoris, and here's gastrocnemius. Here's plantaris and popliteus. Now we'll move on to look at the principal veins, arteries, and nerves in the region of the knee. We'll begin where the sort mass, just below the hip, with follow them to just below the knee. With the main artery and vein, there's a change of name we need to understand. In the upper and middle part, they're known as the femoral vessels, but below the upper hiatus, they're called the popliteal vessels. The same vessels, just a different name. Here's the thigh with the skin removed, and the strip of subcutaneous fat taken out so that we can see the long saphenous vein. Here it's in the middle of its course from the ankle to the top of the thigh. To see the femoral vessels, we'll remove the superficial fat and deep fascia. Here at the femoral artery and vein, at the point where the sort last, disappear beneath the sartorius muscle. To follow their course, we'll remove sartorius and also gracilis. Here's vastus medialis. Here's adductor longus, with adductor magnus behind it. The femoral vessels pass beneath the roof of the adductor canal and through the adductor hiatus. To see where they go, we'll remove semimembranosus and semitendinosus and go up to the back. Here are the vessels emerging behind adductor magnus. They're now known as the popliteal artery and vein. A little above the knee, the popliteal vessels are joined by the sciatic nerve. At the back of the knee, the popliteal artery lies deep to the nerve and to the popliteal vein. To see the artery better, we'll go to a different dissection in which the muscles are intact and the nerve in the vein is completely removed. Above the knee, which is just here, the popliteal artery gives off these two superior genicular arteries, lateral and medial. At the knee, it gives off these strands.
Now, genicular artery, the in the knee joint. Then there are it will be in your this thing of the blood circulation of the knee joint.
We'll see where the lessons go from there in the next section. Now let's look at the nerves. In the last section, we looked at three major nerves: the obturator, the femoral, and the sciatic. We'll follow the sciatic nerve in a minute. Obturator nerve and the femoral nerve we don't need to follow any further, except to remind ourselves of the muscles that they supply. As we've seen before, the obturator nerve supplies obturator externus, adductor brevis, and longus, and the anterior part of adductor magnus. The femoral nerve supplies the ligaments, tibias, all four heads of quadriceps, and the sartorius. The obturator and femoral also have sensory branches, some of which go below the knee. We'll leave these out. We'll go on now to look at the sciatic nerve. We saw the sciatic nerve a minute ago with the hamstring muscles absent. To see the whole picture, we'll add the hamstring muscles. Here are semimembranosus and semitendinosus. Here's biceps femoris. Here are two heads of gastrocnemius. The space that's bounded by these muscles is called the popliteal fossa. In this section, the sciatic nerve passes deep into biceps femoris. Here it is emerging.
See, your now what I want to say this videos, I'm just doing your we are just descriptive, we are drawing some things and then we are saying real anatomical position, you know, how to hold it, that's one prime side determination, that is one criteria. You have to gain marks actually. So, why I want to mix and match the video component and the thing you are seeing in the bone. But you have to coordinate the imagery with the osteology part and the respective muscle and also the movements. Along with it, you are getting the your blood vessels and nerve supply and everything. Now thing component you don't see separately. We don't see, but you have this huge the thing. The chapter is there. That's why we have broken up and given you. But that portion, that whole, these 5 videos, you break up according to your lesson that will be taught to you. You just coordinate. 1 or 2 days you will be the same. You buy a pen drive, take it and see it in the laptop or with a USB port. You can give it to this thing attached with your tab also. You cannot download this. 2005 and 2025. So that time this costs around 1 lakh rupees. Now, what I want to say is that, see, I've been interacting. I won't say I teach with you people, that you must get the core of the subject. Any subject you are reading, you don't think of cancer. You don't think of any big things. You think of what are the possibilities in simple, any lymph node in the neck. Don't think of don't have an obsession that it will be a cancer. No. You think of tuberculosis. You think of some inflammatory reaction in the scalp or in any abscess or something like that. What I want to say is that, see, sartorius. Now, what I am told you, semimembranous, semitendinous. Now, these 3 muscles are here, gracilis. Now, sartorius, where is the anterior superior iliac spine? It is talus muscle. Why it's called a talus muscle? Because the talus, when they are, especially with hand you can operate the machine, your sewing machine, and also there is one the thing tailors are using that have a thing with the pedal. So they are operating the machine with pedal, and their both hands are operating. But in future, if a person who's a tailor, might be his sartorius will be a bit muscular, more muscular, and but nowadays modern computerized or your electric motors are incorporated in sewing machines. So what I want to say, the sartorius muscle, where it is getting used here. Gracilis, where it's originating, is here. You will see it in the dissection hall. But why we are teaching you osteology? Why we are not taking you to the hall and seeing you, telling you this is muscle, this is muscle, this is muscle. It has a system. We have a system. We have been the whole medical world of teaching anatomy, and nowadays it's a course of say 1 year. Now in 1 year, grasping things is a bit tough. So you mix and match and mix with your electronic gadgets and your this thing. But I tell you, attending, I don't know, I have not sat on online, those who are teaching anatomy, Jaidi or something like that. What is his experience? I'm not questioning. It might be, you might be feeling that you attend today, if you are download and see Jaidi. Does he explain this? In this way is it explained? I'm just naming because it came into my mind. But you have to get it, at least some impression in your brain. It is not what is done. He is downloading from many books, and he is also has chosen a font that is like he's writing on board and chalk. But you will see, but I get fascinated with this because you can see how the collateral ligaments. I have been studying, I've studied anatomy in 75, 76, 77, 2 years. Now, what I want to impress is that you can see the collateral movement. They're showing you. You can see the plasticized brain. Professor Higgins, his wife, brought in a suitcase parts of the body in 2 suitcases in Singapore conference. And suddenly the plasticized brain fell from his wife's hand, and she got scared, you know. Scared means in this sense I'm saying she thought that Professor Higgins will shout at her or tell her, hey, why you are done? Don't be careless. Okay. But you can feel it. What you feel in the brain, in the dead body, you can feel it. But it doesn't get fragmented. It doesn't get destroyed. And these muscles, these processes, such a this thing that you can see, you have you have seen, and a team of experts are making this video. The illustrations and the this thing, whatever you spend for this inferior extremity, and also you have to revise for your vertebrae and all this, whatever is the your thorax and lumbar region. You please Take it in your pen drive. I have been requesting all the batches. And you have your notebook, you see the video and start, and then you correlate to the text. Text will be in the left side, in front of the screen, but not in a mobile. Mobile actually you have to do this, expand on this. You waste so much time. You have no time to lose. এখানে খাতা থাকলো, এখানে বই থাকলো, সামনে স্ক্রিন থাকলো. You can do, it's just a practice. You can do, just one thing I tell you, operation theatre. Suddenly I tie a tourniquet around the penis, then I inject. My assistants are there. Though every your senses, you have to train yourself. When you go when you will become surgeons or this thing, robotic surgeries. In Calcutta Medical College, there is robotic surgeries. In Asansol, there is robotic surgery. But Asansol was in a back foot in healthcare. But they are doing robotic surgery there. So you will be part of a team. So you study together. If you don't have a laptop, don't be sad. Your roommate has it. Not like your kindergarten or your schooling. Mummy bola ke nahi dena note. So those days you forget. And you please, for this chapter, lower limb, आप लोग वीडियो का साथ synthesize, you coordinate and sit. देखो तुम कौन ताड़ाताड़ी होच्छे ছবি আঁকলে দেখলে রাখালে নোটটা চট নোট দিও তারপরে তোমাকে তো রিভিশন করতে হবে তোমার ওই খাতাটা থাকবে বইটা থাকবে তখন এই ভিডিও দেখবে না মানে 6 a.m. 8 a.m. to 5 p.m. This is how many hours? I was bad in maths, that's why I came to medicine. Otherwise, I would have been an engineer. But I'm telling you, you just now, you have to, time management is very, very essential. But your enjoyment will be there, your recreation will be there. You will find be feeling bad. Someday you don't want to study, you don't want to do anything. Sit quiet, hearing music or go out. But going out Saturday, Sunday, because you will be losing many things. Your conscience will be thinking, oh, मेरा तो भागना है. अगर Monday, Tuesday, अगर special party है, कोई birthday party है, तो you can do that. That's your private affair. But I'm telling you, you please coordinate the video with your screen. I would say screen and your book and your khata, your notes. যখন বলছে যে this is crucial, just you draw a figure like this, and from your book you draw, and when he's explaining in the video, you just see, and then you put a color or shadow, then write the anterior crucial figure, posterior crucial. 10 marks question or 5 marks question में आएगा, आज नहीं आएगा तो आपको पूछेंगे क्या पूछना है दो तो मसल सोलियस का और पॉपुलेटियस पूछेंगे कब where it is originated and where it is inserted populatius. When we ask you locking unlocking of the knee joint, that's in viva will be there. So that illustration, your image, photograph. I'm telling you, I have been doing biomedical photography from 1975 till date. I have some hundreds of photographs. And in honey research, in one patient with a diabetic foot, I have 100 frames or 75 frames, 500 frames, 50 frames, 25 frames. According to the healing time, I capture and I supervise my dressing. So nothing is impossible. don't feel depressed. Don't feel depressed. Where you do, because you have the in our time, my roommate, he was bit poor. So at times his, by post, अभी तो money transfer, छट, मम्मी भेज दो टाका, तो भेज देते हैं. So in that time, by post or by your post office or your bank transfer, so that is, I used to, at times I used to pay the examination fees for him. So you have no worry for all this. You don't have no worry for food. You have no worry for anything this thing. So you just, I pray that you do well in 2025 and you shall start a new chapter on the lower limbs. ठीक है?